Who is going to present?
So, yeah.
Oh, you, okay.
Yeah. Yeah.
I can just do a quick.
All right.
update, yeah.
Yeah.
Someone on Zoom confirmed they can hear us.
We can hear you.
Great, thank you. So I think it's at the hour, so we'll just go ahead and get started. And today we have some wonderful fellows presenting, but just to remind everyone that this is a CME offering. And so the number is 47,800. And please ensure you get your CME credit. Just a reminder, we have busy end of the academic year ahead of us and a few visiting professors in between several fellow presentations. So next week we have Kenny and Sean. And then after that, later on that week, during the internal medicine grand rounds, we have our annual Massimo Calabrese lectureship. And so I encourage you strongly to join us in celebrating Joe Wu, who is a former graduate of the school and one of Al's former trainees, who is also recent past president of the American Heart Association and runs the Cardiovascular Research Center at Stanford. He's a phenomenal scientist and colleague, and excited that he's joining us. He will also, during that period of time, give a fellows luncheon, I believe, as well. And so more information to come out on that. I know, not to put him on the spot, but Jeff, anything that you need to remind us about Joe's visit with us, the Calabrese lectureship?
No, it'll be a great grand round. Also, there'll be a 1 p.m. after fellows lunch, lecture, seminar, and that'll be maybe a little bit more scientifically deep than typical grand rounds.
Great. Okay. And then the following week, Michelle Kittleson, who is well known to all of us and actually visited us earlier to give an honorary lectureship for the Department of Medicine, is coming to give the Woody Lee honorary lectureship and be visiting professor with us. And then we'll have Divya and Lindsay follow up later in the month. So really very busy time, and I encourage everyone to do your best to be in person. To both Michelle and Joe are coming from the West Coast, so if they can get on a plane and get on here, it'd be for those who can, it'd be wonderful to recognize them by your presence in person. Just for disclosures, here's our information, and then without further ado, I'm going to have whoever is presenting our speakers, Rachel and Tilla, come up and introduce them. Thank you.
Well, this is my honor and privilege to present to you Dr. Catherine Wright. Kate is originally from Singapore, and she went to medical school at the University of Miami. Not medical school, she did her undergraduate at the University of Miami in neuroscience, and then continued her journey at Vanderbilt, where she did her medical school. And after that, we were lucky to recruit her to our internal medicine training program here at Yale, and she stayed on for cardiology fellowship. And Kate has been doing a fantastic work in multimodality cardiovascular imaging, leading multiple impactful projects, including some of those with exploring racial disparities in stress testing and investigating allograft vasculopathy and the role of PET imaging for its diagnosis, and involved in multiple cardio-oncology projects. So she's doing stellar work, and we are extremely happy to recruit her for advanced cardiovascular imaging fellowship and also for cardio-oncology fellowship. So we are really looking forward to your lecture.
And I'm very pleased to introduce Giorgio Matolo. Giorgio graduated medical school in Genoa in 2013, and then spent some years doing basic science research, and then came to do residency here at our program in Bridgeport. He then came here to Yale and New Haven as a fellow on the T32 in 2020, where he spent some time doing basic science with Dan Grafe, and is now pivoting to electrophysiology. We're really looking forward to having him join us in July and to his presentation on the arrhythmic aspects of AMVP.
Thank you so much, Jennifer and Dr. Lambert, for introducing us. And I'm Kate, it's Giorgio. We are very happy to present to you our grand rounds today on the mitral valve and associated arrhythmias. And at the top, we'd like to just, again, thank our mentors who, without this, this presentation would not have happened. Dr. Lambert, Dr. Akidoye, and Dr. Ferrer. So both Giorgio and I do not have any disclosures. Some learning objectives, we are really going to dive into the mitral valve and talk about arrhythmogenic mitral valve prolapse and mitral annulus disjunction arrhythmic syndrome. We are going to talk a little bit about the imaging modalities that can help with diagnosis and risk stratification, and some management options in patients with these syndromes. So to begin, we would like to, like all good grand rounds, start with a case. So this is a 44-year-old lady who is presenting to EP clinic for palpitations. So 15 years ago, she was diagnosed with mitral valve prolapse. And since then, over the past 15 years, have actually not had much symptoms. Once in a while, she will have some palpitations about once a year with stress. She initially presented to cardiology 2 months ago. With worsening life stressors, she felt more frequent palpitations. And one day, just feeling under the weather, she took some cold medicine, felt very lightheaded with worsening palpitations, and thus presented to the ED. In the ED, because she reported that she was feeling mild palpitations, she was placed on telemetry, and she was actually noted to have very frequent PVCs and ventricular bigeminy on telemetry. So this is actually a rhythm strip, a 12-lead rhythm strip printed out from the ED. And interestingly, her PVCs almost look as if they have a right bundle branch block pattern in V1, and the transition varies on this ECG, but in most bits it transitioned before V5 to V6. So there was some suspicion of maybe a posterior medial papillary muscle origin of the PVC. So she underwent an echo while under observation in the ED, and her echo showed myxomatous mitral valve with bilifted prolapse. And her echo, this is not the best frame for it, but it also showed mild to moderate mitral regurgitation, which has increased from just the minimal mitral regurgitation 15 years ago. So with all this, especially given the frequent PVCs, ventricular bigeminy, and now progressive mitral regurgitation, cardiology was consulted by the emergency department, and they saw her in the ED. They cleared her to go home. She was started on metoprolol 25 milligrams daily and was given a 2-week monitor. In the clinic in EP today, she noted that with the metoprolol, her palpitations have improved, but they're still present. They're bothersome and they're anxiety provoking. She also reported feeling lightheaded about 2 to 3 times a week, about 20 minutes each time. And on further history in the clinic, she reported one prior episode of syncope. Quite a few years ago at the dentist, she received a painful shot of Novocaine, then felt hot and lost consciousness. For her family history, her maternal grandmother has a cardiac device, but she did not know whether this was a defibrillator or a pacemaker. And she has one great uncle, which is her maternal grandmother's brother, who unfortunately had sudden cardiac death while dancing in his 60s. No other sudden cardiac deaths that she knows of. And the plan from the clinic visit was to obtain a cardiac MRI to look for characteristics of arrhythmogenic mitral valve prolapse and to increase her metoprolol to 50 milligrams daily. So this is some representative images from her MRI. And on her MRI, it looks like there is prolapse of bileaflets in the mitral valve, which is already known on echo. And there's mild mitral regurgitation, which was known to be 17% of regurgitation fraction. It was also noted that she had about a 3 millimeter mitral annular disjunction right here. And where the arrow is pointing to, there on post-contrast delay images, there was a possible focal enhancement at the tip of the posterior papillary muscle. So the question that was raised was that, is there any correlation between the patient's known mitral valvular abnormalities and her ventricular arrhythmias? And with that, we'll dive into mitral valve prolapse and mitral annular disjunction. So a little bit of historical perspective. There was a 1981 American Heart Journal case report, which described a 45-year-old male physician. He had a long history of palpitations. On physical exam, he was reported to have a mid-systolic click and late systolic murmur. He underwent a Holter monitor given this history of palpitations, and he was known to have frequent PVCs and 3 to 5 beats of NSVT. Unfortunately, he declined further medical care, and he had a sudden cardiac death a year later. On pathology, post-mortem, he was known to have markedly thickened a redundant posterior mitral valve leaflet, and the mitral valve was attached to the atrial side of the annulus. And this was likely the first described case of sudden cardiac death with mitral valve prolapse and mitral annular disjunction. So for mitral valve prolapse, the definition is superior displacement of the mitral leaflets of greater than 2 millimeters above the mitral annular plane in a long axis wheel into the left atrium during systole. It can affect one or both mitral leaflets, and it can be due to disruption or elongation of the leaflets, chordae, or papillary muscles. Mitral valve prolapse can be associated with fibromyxomatous degeneration of the leaflets with a maximum, and if there's a maximum thickness of more than 5 millimeters during diastole, that's known as Barlow's valve. But you can also have mitral valve prolapse without mitral valve thickening. This is a pretty common condition, which is present in about 1 to 3% of the population. Arrhythmic mitral valve prolapse. The European Heart Rhythm Association definition is the combination of mitral valve prolapse with or without mitral annular disjunction with frequent or complex ventricular arrhythmia in the absence of any other well-defined arrhythmic substrate. And that's regardless of mitral regurgitation severity. And in the EHRA guidelines, they called out the diagnostic criteria for arrhythmic MVP. Again, presence of mitral prolapse without mitral annular disjunction, which we'll get to in a bit, and the presence of ventricular arrhythmia that is both frequent or complex. And two phenotypes that we can think about with arrhythmic mitral valve prolapse are one due to severe degenerative mitral regurgitation that is they do carry a higher risk of excess mortality, including excess certain cardiac death, as compared to the general population, and irrespective of valvular morphology. And the second type is due to severe myxomatous disease, irrespective of severity of mitral regurgitation. So these are patients with severe myxomatous disease with market redundancy, excess leaflet length and thickness, and mitral annular disjunction. I think, in here they talked about and, but according to guidelines, it's with or without. And irrespective of degenerative mitral regurgitation severity, they are prone to develop arrhythmia over time. So we have talked a lot here about mitral annular disjunction, and this is a phenomenon that I think finding that we have noted more with more cardiac imaging. There's increased awareness that this some patients have this finding on MRI or echo, which is an abnormal atrial displacement of the hinge point of mitral valve away from the ventricular myocardium. The true definition of what exactly a mitral annular disjunction is remains debated. There's no really good cutoff of the length that you need to have to qualify for mitral annular disjunction. And one study noted that the prevalence of mitral annular disjunction can vary by about 300% based on the imaging modality and diagnostic cutoff. The clinical significance of a mitral annular disjunction by itself is currently unclear. There are some studies that point out an association between MAD, ventricular arrhythmia, papillary muscle fibrosis, but that is part of the mitral valve prolapse arrhythmic syndrome. Others propose that mitral annular disjunction in itself could be an arrhythmic entity. So in the European Heart Rhythm Association guidelines, they summarize some diagnostic criteria for mitral annular disjunction. So the key things that they wanted to note are that this is an anomalous attachment of the posterior leaflet directly on the atrial wall. Some associated findings include curling, which we'll get to, and they recommend sagittal views for identifying MAD and for assessing its length. Echo is preferred as a first-line imaging test for MAD due to its wide availability, and its MRI can be considered in patients with port windows. And MAD requires dynamic evaluation throughout the whole cardiac cycle, and apical views should be used for evaluating the extent of the rift. This is a table summarizing some studies for mitral annular disjunction that have been done. Most modalities here are echo and CMR. And as you can see, the extent of MAD really differs based on the studies and the modalities, and the prevalence also based on the definition of MAD by the authors vary all the way from 20-something% to 100%. So here at our core lab, we also have some mitral annular disjunction images. So on the shorter spectrum, we can see mitral annular disjunction of about 3 millimeters, and more dramatic ones are 14 millimeters on the longer side. And with more recognition of mitral annular disjunction and the spectrum that you can present with regards to how much disjunction there is, there's more thought about the exact location of where mitral annular disjunction can actually be thought of to be a normal variant or pathological variant. So this is a UK Biobank imaging study, which had 2,600 patients, and they found that there's actually disjunction in about 76% of people who have undergone CMR. And disjunction is associated with both prolapse and billowing of the mitral leaflet. Specifically, they thought that extensive inferior lateral disjunction could be pathologic and other disjunction could be normal variants, but again, more studies are needed. So there is a entity known as pseudo mitral annular disjunction, and that's why dynamic analysis was called out as being important to differentiate true to really diagnose mitral annular disjunction. So in true mitral annular disjunction, there's discontinuation between the attachment of the mitral leaflet and the myocardium of the LV3 wall. And in pseudo mitral annular disjunction is actually a sort of imaging finding due to the presence of mitral valve prolapse. The annulus plane can be set erroneously at where the leaflet is bending in the atrium, and that actually causes a illusion of mitral annular disjunction. And this is just a picture of what we have talked about so far, a normal mitral valve with a mitral annular plane without any prolapse of the mitral valve leaflets, mitral annular disjunction by itself without any prolapse, mitral annular disjunction with prolapse, with the valve, with the annular plane measured where the leaflets are attached to the myocardium, but not where it's bending. And we would move forward to Giorgio to talk about some of the proposed mechanisms of ventricular arrhythmias.
Thank you, Kate. So to understand how mitral valve prolapse can produce ventricular arrhythmias, I will briefly go over the first study that attempted to explain this mechanism. So this study is from 2015. It looked at 650 autopsies to start. And these were people that suffered sudden cardiac death. They were 40 years old or younger. 43 of these patients had mitral valve prolapse as the only abnormality identified on autopsy. Only 12 of these patients had ECG data, and interestingly, all 12 of these had ventricular arrhythmias with right bundle branch block pattern consistent with left-sided ventricular ectopy. But even more interesting, all of these patients had papillary muscle fibrosis on histology, and most of them had fibrosis in the basal inferior wall. So these findings were quite interesting, and the same study group sought to confirm or validate these findings in a living patient cohort using MRI. So they took 44 patients with mitral valve prolapse, 30 of which with a history of any VT or VF, and 14 without any VT or VF. And as expected, the majority of patients with history of VT-VF had LGE on MRI, and a much smaller proportion of the mitral valve prolapse patients without VT-VF had LGE. And let's look at some examples. So you can see here on histology samples from 3 of the autopsies, you can appreciate collagen scar in blue, interspersed in the myocardium, localized in the basal inferior wall, and this is the anterolateral papillary muscle of 3 patients. And in the living cohort, this is an example of a 33-year-old that had mitral valve prolapse and VT, that had LGE in the basal inferior wall with a PVC morphology that matched this location. And so over the last several years, studies have suggested that in patients with mitral valve prolapse, the mechanical stress exerted on papillary muscles and the basal inferior wall over time can produce scar and acts as a trigger for ventricular ectopy, which in turn can result in high PVC burden and or VT-VF. And so taking a step back and going back to our patient, her Holter study showed, as I depicted here, a high burden of PVC, 10%, and numerous short episodes of VT as fast as 184 beats per minute, which is quite fast. And if we look at the PBC morphology again on a 12-lead ECG, you can see that they have essentially they're negative in 2 and 3, so they have a superior axis. In V1, they have a right bundle branch pattern that transition in V5. All of this is consistent with the LG that Kate showed before and the posterior papillary muscle. And so now I will switch gear and talk about risk stratification and markers of risk, including MAD, that can help us making management decisions about these patients. So why is risk stratification important in these patients? So as we know, mitral valve prolapse can be associated with arrhythmias and sudden cardiac death. As Kate alluded to earlier, mitral valve prolapse is common, is the most prevalent valvular abnormality in Western countries, estimated at about 2 to 3% in the US across all ages, with reported prevalence increasing with age. And risk can be mitigated with several tools that we have at our disposal, as we already do for other conditions that are better studied, like hypertrophic cardiomyopathy, for example. But unfortunately, there's no guideline, there's no recommendation on rhythm monitoring and management for these patients in the current valvular guidelines. And just to give you an idea of the size of the problem, we can compare mitral valve prolapse with hypertrophic cardiomyopathy that I just mentioned. So in relative terms, as you can see on this graph, sudden cardiac death is much more common in patients that are affected by hypertrophic cardiomyopathy compared to mitral valve prolapse. But mitral valve prolapse being so common in the general population contributes to more events compared to hypertrophic cardiomyopathy. And now, assessing risk of sudden cardiac death in mitral valve prolapse patients is quite challenging, and reported rates of sudden cardiac death vary across studies. What makes matter even more complicated is the fact that mitral valve prolapse patients make up a very heterogeneous population, with subgroups having the same risk of sudden cardiac death as the general population, while others have a way higher risk of sudden cardiac death. So the question is, how do we identify these higher risk groups? And several studies have looked at this over the decades. This one, for example, looked at patients with flail mitral valve leaflet, most of which had significant MR. And you can see that the authors showed that heart failure symptoms, LV dysfunction, the presence of atrial fibrillation are associated with higher rates of sudden cardiac death. This is a different study showing that patients with mitral valve prolapse that have no MR essentially have the same mortality rate as the general population. And not surprisingly, as the severity of MR increases, mortality increases as well. But then the question is, does MR really tell the whole story? And this study, for example, shows otherwise. These are 600 mitral valve prolapse patients that were enrolled and underwent a baseline Holter study before the study actually started to assess baseline ventricular arrhythmia severity. And these patients were then followed over time, and more severe arrhythmias defined here correlated with higher risk of death alone or compounded with rates of ICD implantation or VT ablation. Furthermore, the authors also found patient characteristics that correlated with more severe ventricular arrhythmias independent of MR severity and LV EF. Namely, these were mitral annular disjunction that we talked about, redundant leaflets, and repolarization abnormalities on ECG. And in this subsequent study from the same group, a mitral annular disjunction was associated with more arrhythmias, but interestingly, it was not associated with a higher risk of death. So these curves look exactly the same. So clearly, more studies are needed to clarify a potential link between mitral annular disjunction and increased mortality in these patients. So, and Kate already alluded to this, but as you can see, like the current evidence delineates the two main arrhythmic mitral valve prolapse phenotypes. One that has significant MR, and another one that is independent of MR, with the latter being mostly associated with mitral annular disjunction. There's also somewhat of a third entity that is under study as perhaps controversial, which is mitral annular disjunction without mitral valve prolapse. And now I'll hand the talk over to Kate again, and she will tell us about how imaging can inform risk stratification.
All right, so as Giorgio was talking about, the overlap between mitral valve prolapse, mitral annular disjunction, arrhythmic syndromes, it's still not completely understood, but there are some things that can help with getting a little bit more information on risk stratification for our patients. So as recommended by the European Heart Rhythm Association, the first imaging modality should be an echocardiogram. So with echocardiogram, some things that we can take a look at for mitral valve prolapse, again, are the evaluation of leaflet length, redundancy, and thickness during diastole to help us decide on the really the myxomatous degeneration part of the picture. 3D echo can also be used to estimate the extent of prolapse segments. Some findings to take note of, Doppler tissue imaging of the lateral mitral annular velocities can help inform risk. There is the Picker-Haupt sign, which is a peak systolic lateral mitral annular velocity of greater than 16 centimeters per second, which is this pig here. Is named after the German military helmet with its sharp little pig. And this is due to the tugging of the posterior medial papillary muscle in mid-systole by the myxomatous prolapsing leaflet, and that causes the adjacent posterior basal left ventricular wall to be pulled sharply towards the apex. And this finding specifically, which can be seen on both echo and MR, is associated with a higher risk of malignant ventricular arrhythmias and also the presence of late gadolinium enhancement. So for the evaluation of mitral annular disjunction on echo, again, it should be the first line of imaging to measure the distance between the mitral annulus and the ventricular myocardium, and also to determine the location of the disjunction. There are some dynamic findings that can be seen, including hypermobility of the mitral valve apparatus, paradoxical systolic increase of the mitral annulus diameter, and systolic curling, which is increased mitral myocardial function right adjacent to the prolapse leaflet. And specifically, if there's focal hypertrophy of the left ventricular base with a basal to main left ventricular wall thickness ratio of greater than 1.5%, that's suspicious. Moving on to cardiac MR, MR can also help add additional information for both arrhythmic syndromes. So on cardiac MR, you can have visualization of the extent of leaflet prolapse and measurement of the distance of mitral annular disjunction. It can also help with finding focal myocardial fibrosis using the gadolinium enhancement. So these are some pictures of a case report of a patient who was known to have mitral valve prolapse in the posterior leaflet and just mild to moderate mitral regurgitation, kind of like our patient. He was asymptomatic and was just recommended for routine follow-up. Unfortunately, he presented with a out of hospital arrest with VFib. And in his case, putting all the images together, you can see a prolapse with also mitral annular disjunction, cardiac MR with LGE with a predominantly subendocardial scar in the mid-inferior lateral segments, and CMR showing the mitral annular disjunction again of 13 millimeters, which is quite dramatic. And this is actually his intraoperative image of his severely degenerative myxomatous mitral valve and the histology H&E staining of the myxomatous degeneration. So speaking of fibrosis and LGE, fibrosis is actually pretty common in mitral valve prolapse. About 30% or more, and it's usually located adjacent to the mitral annulus in the basal left ventricular wall and can include papillary muscles and the inferior inferior walls. So we have spoken a lot about systolic curling. This is a really good clip of what that means. This is a patient with mitral annular disjunction and associated systolic curling. You can see there's the hypermobility of the left ventricular wall right next to where the mitral valve is prolapsing. Right, and further evaluation on CMR, the presence of late gadolinium enhancement itself is associated with complex ventricular arrhythmias. In some places where we can find LGE includes, again, the mitral apparatus, so the papillary muscles, especially in the mid wall of the papillary muscles in the periannular region. You can also see non-ischemic LGE, so patchy myocardial LGE, again, focused in the inferior basal region. And in some patients, you can see diffuse interstitial fibrosis, particularly, again, involving the basal segments close to the mitral annular apparatus. So these are some pictures of patients with bileaflet prolapse and mitral annular disjunction right here with the yellow arrow, and just some representative LGE, so classic non-ischemic looking LGE, mid-myocardial, and patchy. Right, and some, I think, more imaging studies that are coming down the pipeline, more interesting combination imaging. So there has been a group that put out a study of a hybrid FDG PET and MRI imaging on some patients. So it's a very small study of only 12 patients, but they had some pretty interesting results. So these 12 patients had degenerative mitral valve prolapse, ventricular ectopy, and mild to moderate MR. So the exact type of patients that we're thinking about for risk stratifying for arrhythmogenic mitral valve prolapse. And they found that in these patients, myocardial inflammation is concordant with myocardial scar on this type of hybrid imaging. So again, putting everything together, this is a patient with bilateral mitral valve prolapse, and this is the pickle hop spike at 26 centimeters per second, the NSVT that she had, and the focal fibrosis here on cardiac MR that correlates very nicely to higher uptake with FDG images. Right.
All right. So what can we do for these patients? As I mentioned before, there are yet no guidelines to help us manage these patients. However, the European Heart Rhythm Association, which we have heard a few times now, published this consensus a few years ago to give us some guidance based on the current evidence. So while we have several tools in our armamentarium to manage these patients, we must make a clear distinction between interventions that are known to prevent sudden cardiac death as opposed to suppress ventricular arrhythmias. Whether the latter ones can improve sudden cardiac death rate is unknown. But talking specifically about ICDs, the standard of care for primary and secondary prevention of SCD still applies for mitral valve prolapse patients, and we're all familiar with these indications. But the European Heart Rhythm Association proposes a few additional recommendations that are more specific to mitral valve prolapse patients. So, for example, if we have a patient presenting with unexplained syncope or pre-syncope, if this patient also has at least two of the phenotypic risk features that we discussed, most of which rely on imaging, it is reasonable to consider this patient for an ICD implantation. Similarly, association with this clinical presentation with evidence of VT coming presumably from the mitral valve apparatus, also these patients should be considered for an ICD. And finally, they also recommend considering ICD implant for patients that have at least 2 of these risk features with documented VT of any kind. And this is a very recent study. I think it was just published a couple months ago. And it's the first one reporting ICD outcomes specifically in patients with mitral annular disjunction. It's a small study, as you can see, 49 patients. And very interesting is the fact that 5 of these patients actually had a normal mitral valve. So they only had like kind of what I mentioned before, mitral annular disjunction isolated from mitral valve prolapse. So most of these patients had secondary prevention ICD. Others had a primary prevention ICD. You can see the indications here. And you can see that appropriate shocks were common. I believe this is 37% of the total, mostly for polymorphic VT and VF. But inappropriate shocks were common too, and this is 10% of the total. So needless to say, ICD use needs to be studied further in this population. And so putting ICDs to the side, antiarrhythmic drugs can be used to reduce frequency of ventricular arrhythmias. And as you can see, the EHRA recommendations are essentially the same as those for patients without mitral valve prolapse, since medical therapy has not been specifically studied in these patients. Catheter ablations can be used for similar indications and can be particularly helpful in patients where antiarrhythmic drugs are contraindicated or fail. I will try to summarize a few interesting studies that have looked at catheter ablation outcomes in mitral valve prolapse patients. So this study looked at patients undergoing PVC-VT ablations with the mitral valve prolapse subgroup that is quite small. As you can see, it's only 14 patients. But the authors showed that freedom from ventricular arrhythmias was essentially the same comparing papillary muscle ablation compared to other locations, despite the former being generally more challenging technically, and also a common origin for ventricular arrhythmias for these patients with mitral valve prolapse. Focusing on papillary muscle ablation alone, you can see that the outcomes between comparing patients with mitral valve prolapse and no mitral valve prolapse were essentially the same. And focusing on papillary muscle ablation, you can see that there was a significant PVC burden reduction after ablation at 3 months. As you notice, quite remarkably, all these patients started out with a very high burden of PVC. These patients also saw recovery of their LVEF. This is another study with a small mitral valve prolapse patient subgroup showing that the success rate acutely was high. And they also had a significant reduction of PVC burden after papillary muscle ablation. In this yet more recent study, investigators looked at ablation outcomes specifically in patients with both mitral valve prolapse and mitral annular disjunction, also showing high success rate acutely of ablation, as well as significant reduction in PVC burden. But one additional interesting point in this study is that 18 of these patients had abnormal electrogram signals that were coming from the mitral valve apparatus. 10 of these patients happened to have a pre-ablation CMR, and only 4 of these 10s had LGE on MRI. And this suggests that abnormal electrograms may not always correlate and perhaps may even precede evidence of scar on MRI. What about mitral valve surgery? We all know that surgery is the mainstay therapy for severe primary MR, but there are 2 outstanding questions. So does surgical correction of MR decrease ventricular arrhythmia frequency? And can ablation be added to mitral valve surgery to reduce arrhythmia burden? In this arena, there's a few interesting studies that I want to share with you. So this is actually one of the studies that I showed you earlier that correlated the severity of baseline ventricular arrhythmias with worse outcomes, looking at all of the enrolled mitral valve prolapse patients. But what happens if we stratify patients by those who received medical therapy alone versus mitral valve surgery? You see that in patients treated conservatively, what you see here, the association between arrhythmia severity and hard outcomes is strong. On the other hand, in patients who underwent mitral valve surgery, this association becomes much weaker and statistically insignificant, suggesting that surgery may help mitigate arrhythmias in these patients. Another study from about a decade ago looked at a small group of mitral valve prolapse patients who underwent mitral valve surgery for MI. Looking at all of these patients together, ventricular ectopy did not change after surgery. See, it's just a flat line. But if we stratify by younger versus older patients, the former had decreased ectopy, and the older patients had increased ectopy. And this perhaps suggests that the younger patients were like kind of earlier on in the natural history of the disease and may have more antiarrhythmic benefit from the surgery. Finally, I wanted to show you two small case series I paired together in this slide, just looking at the use of concurrent cryoablation with the mitral valve surgery, like you can see depicted in the cartoon. On the left, you see 3 patients who had high burden of PVCs, and after surgery and concurrent cryoablation had a remarkable reduction in ventricular arrhythmia burden, with the longest follow-up at about 6 months. And then on the right, you see these 3 patients that had, all of them had ICDs and recurrent shocks. And actually 2 of these failed catheter ablation. So they, again, underwent mitral valve surgery with cryoablation. And these 3 patients became free of shocks after surgery and cryoablation for as much as 9 to 10 years. So these are the longest follow-up among these 3 patients. So in summary, all of these interventions have potential to reduce burden of ventricular arrhythmias, but more studies and especially clinical trials are needed to prove their benefit. So let's try to put all of this together using the management algorithm proposed by the EHRA. So mitral valve prolapse patients present along a clinical spectrum of risk, as we have learned. But in patients who are asymptomatic or symptomatic without a clear history of cardiac arrest, Holter monitoring is a reasonable first step to screen for or detect arrhythmias. Patients with prior documented VT-VF arrest should receive an ICD. After Holter, we may or may not detect VT. If we don't detect VT, we can use the phenotypic risk features that we discussed, most of which rely on imaging. Based on how many the patient has, we can titrate the frequency of monitoring accordingly. If we do see VT, it may be high-risk VT or maybe not high-risk VT. High-risk VT, this consensus defines as VT rate more than 100 beats per minute, like our patient, sustained VT not from the outflow tracts, or non-sustained polymorphic VT. If the VT is not high risk, then kind of staying with more aggressive monitoring alone may be reasonable. In case of high risk VT, then the patient should be considered for an ICD. And mitral valve surgery consideration is determined by absence or presence of severe MR. Furthermore, to reduce burden of ventricular arrhythmias, especially if they cause LV dysfunction or symptoms, ablation and antiarrhythmic drugs should be added on as well. So what happened to our patient? So we can place her somewhere in the middle to kind of mid-high risk on this spectrum, and based on her presentation. And on imaging that she had for diagnoses, she also had these risk phenotypic features. And on her diagnostic Holter, as we talked about, she had short but fast VT, which I guess by these criteria would be considered high risk. So putting all of these together, she was considered and she underwent a subcutaneous ICD implantation and she had no severe MR, so she didn't undergo mitral valve surgery. And since she kept having high burden of PVCs, she has been treated with sotalol to address that. And ablation could be a consideration in the future if she keeps having symptoms and high burden of ventricular arrhythmias, especially if antiarrhythmic drugs become contraindicated or undesirable. So that's the end of our talk. So both Kate and I want to give a big thank you to our mentors, Dr. Ferrer, Dr. Lambert, Dr. Akintoye. Needless to say, they were always available to share their expertise throughout the preparation of this talk. So we're really grateful to them. We thank the audience for the attention on Zoom, and welcome any questions or comments. Thank you.
Let's start. Great presentation, very interesting. Emerging evidence in this condition. So I guess a question maybe related to the surgical approach. And I know folks, down the road from us, it's like Dave Adams and others do a fair bit of mitral valve surgery in this population, and particularly among women who present early with arrhythmias. So can you speak to do they exclude the surgical approach? Is it simply the correction of the prolapse, or do they exclude the MAD when it's found? And I'm just curious about whether it's reducing the source of potential inflammation or ongoing inflammation can lead to arrhythmia burden reduction.
That's a great question. So, I mean, I haven't found studies that kind of separate the two. I know that studies that have looked at mitral valve surgery and the effect on ventricular arrhythmias down the line, essentially, they include patients that have mitral valve repair, replacement, and may include actually MAD correction as well. But like these two haven't been really separated in the study, as far as I know. Yeah, so it would be interesting to do for sure.
Yeah, and I think
Yeah, this was showing actually.
yeah. So I like Giorgio say, I don't think anyone has looked into do you just repair the valve? Do you also repair MAD? But there have been some proposals of while you're in there repairing the valve, like in this case, trying to also get rid of the disjunction.
So very nice talk. I enjoyed it. So you mentioned the etiology or pathophysiology of the arrhythmia, but a few words about the annular disjunction itself. How does it come to existence? It's actually there are two genes we normally send in the genetic clinic for patients who have this. One is the DZIP1. DZIP1 is actually DAS-related protein, and that's actually a ciliary protein. Cilia, just for your information, are very important for heart formation. For example, if you have a mutation in certain cilia genes, you have a left and right asymmetry. Cilia are involved in actually every single cell in your body except for hematopoietic cells have a cilia, single cilia, which often is immotile. And those cells actually are regulating signaling pathways such as Wnt signaling, Notch pathways. It's very important for valve formation. So a mutation in that causes that. And there is another one is a protocadherin, which is the protocadherin 16, which is a transmembrane protein, single and it's actually a cell membrane protein. And these proteins have a cell junction protein attachment, but also it's interesting, they bind macrophages as well. And macrophages have been found actually in the conduction system, and they play a role in regulation. And that inflammation that you showed actually in imaging from nuclear imaging can be related to some of these things that actually affects and kind of causes these macrophages to be polarized and become inflammatory. So we actually do genetic testing in patients, especially if they have a family history.
Yeah, this is super interesting, and I try to dive into it as much as possible because I found it really interesting. I think and you can comment as well, but what I guess mitral valve prolapse itself and maybe have in common in terms of what they do to myocardium is increase tensile strength So MAD does it simply because the papillary muscles essentially have more tensile stress because of the chordae. And MAD, as Kate was explaining during the talk, essentially causes the basal inferior wall to have this curling motion. And the curling motion is thought to be at the base of this increased stress that over time, I'm not sure if like the proteins, the pathways that you mentioned are triggered by tensile stress on the muscle. But essentially that's kind of the basis of how MAD is thought to kind of produce these the fibrosis and trigger for PVCs, which together kind of provide the substrate for BT potentially.
Yeah, and I think here, just adding on to what Joe said, where does MAD come from? How prevalent is it? What kinds of MAD are just incidental findings and what are correlated with arrhythmogenic syndromes? I think it's still a area that needs a lot further study.
Great talk, great summary. Thank you. So completely different disease, but in AF, obviously we talk about structural remodeling and electrical remodeling, right? And there's lots of discussion about what causes what and what comes first. And I don't think anyone thinks that ventricular arrhythmias here cause MVP, but I just wondered in terms of electrical remodeling, if you reviewed anything that talked about effects on ion channels. So, you know, maybe structure, but probably more likely number and function of ion channels in this disorder, because there could be a driver mutation that affects channel biology as well as structural remodeling.
Yeah, this is super interesting as well. So, I mean, as more AFib begets more AFib, right? We all know that. And there may be some of that even in mitral valve prolapse. Although I'm not sure that arrhythmia itself kind of perpetuates, like it makes more ventricular arrhythmias happen. I think it's more of the structural changes, but again, it's an entity that hasn't been studied probably as thoroughly. But you know, and the natural history of the disease is really not known. We don't know if MAD could be a precursor of mitral valve prolapse. Sometimes we see it alone. So it's definitely something that needs more studies. But yeah, it's a very interesting concept.
Too, that in addition to this, the types of changes that happen because of the stretch leading to fibrosis, it hasn't really been studied in MVP per se, but stretch does change electrical properties. So there were some old studies that I looked at a while ago that if you just take a Langendorf heart and you just pull on it, you can create after depolarizations. So you can change refractory periods. And so there is impact just from stretch alone, even before you develop fibrosis. So that probably is a piece of it.
I was hoping to talk a little bit about, but first of all, great talk. And it's really interesting discussion. And one of these diagnoses that is one of the diagnoses of the modern imaging age, right? That really wasn't available for us to look at, you know, prior to more high resolution imaging. And that brings up the question, is there a relationship between the degree of displacement of the mitral annulus and the severity of the arrhythmias? Because it seems like echocardiography, we miss those smaller 3 millimeter mitral annular disjunction anatomic features, but we see the larger, more severe 10 millimeter or greater disjunction features. And so where does echocardiography and the sensitivity lead us to wanting to move towards MRI? And I'm also struck by the ability of the German military helmet sign to be able to predict the functional consequences of this. And should we be looking at functional, not anatomic imaging as our screening technique?
I think those are really good points. So I think that gets, pun not intended, at the heart of the issue of what really constitutes a mitral annular disjunction. And right now, we don't really have a good definition. So are those 3 mm disjunctions truly microannular disjunction? Or is there a cutoff where it starts counting to its disjunction? And as we get, to more dramatic, more clearly seen disjunctions, are they associated with more ventricular arrhythmias? We're not entirely sure right now. And it's hard to study because, when you look at mitral annular disjunction and ventricular arrhythmia, you don't really know. These all comers, small disjunctions, big disjunctions. So, and I think it also shows up in the European Heart Rhythm Association guidelines that they give all that great diagnostic criteria for where you should look at, what views, what imaging modalities you should consider, but the glaring omission is how many millimeters. Yeah.
Very nice presentation, Giorgio and Kate. I learned a lot myself by working with you guys on this project. So just to add to your point, I think overall, I think the jury is still out in terms of which one is the problem. Is it the mitral valve prolapse or is it the MAD, right? And it depends on who you talk to. So some people will put more weight on the MAD, while some will put more weight on the mitral valve prolapse. So the consensus statement that you referenced in the presentation, I think that was the first attempt at trying to shed more light on the arrhythmogenicity when it comes to mitral valve prolapse. There's also a recent document that was published in JACC Imaging last year that only look at MAD. So just like this consensus document look at mitral valve prolapse with or without MAD, they look at MAD with or without prolapse, meaning they put more weight on the MAD. So I think, as you guys alluded to, I think there is still more to learn in terms of this particular topic. And as we gather more data, and thank God now in the advent of multimodality imaging, there's more focus and we're able to like separate what is true MAD from pseudo MAD. So I believe as we gather more data, we'll be able to like know exactly which one is a problem and which one we should focus more on. Yeah, so great presentation again.
Last question, I guess, a comment?
I think Rachel will have one more question, but this is not a question, it's just a comment. I think this is a fascinating disease that has so many unresolved questions, and I think molecular imaging could be particularly useful in this setting because it's a very focal disease. It involves inflammation, involves fibrosis, matrix remodeling. So I think it could be a good project for someone who is interested in valvular disease. And I'm not aware of any animal models of it. I don't know whether L has seen any disjunction, annular disjunction in pigs or other animals, but I think it could be a really great project.
I have a question for Attila, Emmanuel, and Kate about the imaging aspect. So when I see these patients, it's because we're starting with PVCs, and then I'm like working up the PVCs, and that leads to the MR and the MVP, and do they need a device? But from you guys' perspective, like if you just have an echo and an MR, and you're seeing, bileaflet prolapse and MAD, and should you guys be reaching out to the ordering doc to look in the other direction? Look for arrhythmias. Is there enough there, do you think, if you're starting from the imaging, to then look for arrhythmias, do you think? What do you think, Kate?
Yeah, I think we have definitely ran into a couple of these situations in the imaging lab where, incidentally, we know that the, say on MR, the mitral valve looks a bit thicker than expected. And they would go hunting. Well, there's some prolapse. We calculate the amount of MR and you look for MAD. I think what I've seen so far, based on working with the attendings, is that we try to highlight that in the impression, in the report, that this is something that you should look towards, that, reporting the extent of MAD and try to link it together with, oh, by the way, the patient has some that's changing in the mitral valve and prolapse, that this should be something that you could look at. And which brings us back to Giorgio's side of really trying to say, well, is this a normal variant that we're now seeing because we're imaging so many more people with more high def imaging, or is this someone who, well, we bring into clinic that says, well, by the way, I've been having some palpitations, and you go down looking for it.
So are you using the phrase like consider AMPP in your MRI?
No, I don't think so. We don't do that, but I think it's as you guys presented really well. It's really a spectrum of disease, and the threshold, the individual threshold for reporting is different. So one person may report an MAD of 2 millimeters, 3 millimeters, because I think in the original paper they use a 2 millimeter cutoff, which is extremely low. But if we see 10 millimeter MAD, I would certainly report it and put it in the impression. And I think it's a relatively low hanging fruit to do some monitoring on that patient, because if they have arrhythmia, I think we have enough to make the case that maybe those patients are at higher risk for future fatal arrhythmias.
To add to that, I think we're still gathering more data, more imaging biomarkers to better risk stratify this patient. Lead length is one thing that has been reported, but what is like the threshold to trigger more aggressive therapy, we don't know, right? So I think one imaging biomarker that has probably gathered more weight is LGE, is a degree of fibrosis. So unlike Kate and Georgie rightly presented, so we tend to have LG in the basal inferior wall or on the head of the papillary muscles. I think we have good number of data that have shown that that is associated with ventricular arrhythmia. So with that, in addition to having high-risk VT, I think that warrant like a discussion too in terms of whether the patients need like ICD or not. Yeah.
Thank you so much, everybody.
Good job. Thank you. Thank you.